Esophageal cancer. In India, colon cancer may not be that prevalent as in West. But in Asia, the incidence of esophageal carcinoma is relatively higher compared to that of the West. Right? Most of these esophageal cancers are above the age of 50. Males 3 times more than females, unlike thyroid cancer where females are more often than males. Alcohol, tobacco, the diet which is very rich in nitrates and nitrosamines. Typically if you go to Chinese population, everything is smoked food. So nitrates and nitrosamines. And some esophageal disorders are also the risk factor. Achalasia. Lot of times this is asked as an MCQ. We'll think achalasia is very benign. No, will it lead to malignancy? Yes sir, it can. It is pre-malignant. Chronic esophagitis, Plummer-Vinson syndrome, then some aflatoxins, very important. Molybdenum is a trace element deficiency which can lead to esophageal cancer. Vitamin A, vitamin C deficiency. Don't think these are the vitamins that are lost into urine if you take a tablet. Their deficiency can lead to esophageal cancer. Celiac disease. Celiac disease. You have the gluten sensitive enteropathy, etc., right? So that also can lead to esophageal cancer. Thyrosis is another important entity associated with esophageal cancer. Risk factors, doctor. If examiner want to ask a question, it is a favorite area. Now, you need to know fundamental structure of esophagus. There is a mucosa, submucosa, muscularis mucosa, no serosa. If you take other parts of the gut like duodenum, jejunum, colon, anywhere, there is a serosal layer around them, right? Peritoneum, mesentery, etc., etc. There is no such covering on the esophagus. Why is it important? Any esophageal cancer, if it is there, since the gate is not there in the form of serosa, it can jump quickly and spread into the mediastinum everywhere, and that will affect the prognosis. So, no serosa for esophagus is what you have to basically remember. So, this is a type of esophageal cancer which is called fungating mass-like presentation, esophageal cancer. There is another type of presentation called as infiltrating type of esophageal cancer. The main idea of running through these images is to get you into that mood of esophageal cancer. Fundamentally, what we are handling, what kind of pathology is happening. So first you like the topic as a clinician, then obviously you will also read it with enthusiasm and fare better in the MCQ exam. If you only look at it like a bundle of high yield facts, you won't enjoy. Let me tell you. Think that tomorrow I may become a gynecologist, but I will have a possible case of esophageal cancer walking in. So if you get into the clinical mood, then only you will enjoy all these clinical subjects. Let me tell you, these are all the patients who are around us, surrounding us with their own stories. Only thing is, we being a single human being, we don't get chance in MBBS to see all of them. We have to imagine lot of things, ultimately do very few things. The difference between medical education and the romantic fantasies of a typical Indian human being who gets married at 35. So, not much different. You imagine a lot, ultimately you will discover that you will do only one thing routinely on one particular branch. So that's the reason, doctor, spread your imagination, fantasize the academics properly. Think that you are handling a patient of esophageal carcinoma, obviously everything will fall into the line. Now doctor, you have done endoscopy. You are having that reddish mucosa which is extending into the gastroesophageal junction. An example of an adenocarcinoma which arises from the lower one third of the esophagus in a case of the Barrett's esophagus. Now, if you look at the distribution of the type of histology in the case of the esophageal cancer, doctor, lower one third, 50% of cases, there will be adeno. Upper and middle one third, 40% of cases, that will be squamous. Why in the modern era, adeno is increasing? Modern era, we are immobile. We are Google, we are Facebook. We don't have energy even to move around to do some basic activities of life also. If somebody can put a bedpan also, we are very happy to sit in the same place. Obesity, more gastroesophageal reflux, leading to Barrett's, leading to adenocarcinoma, is increasing due to increased obesity. Then, what are the important signs and symptoms of esophageal cancer? Dysphagia. What type of dysphagia? First to solids and later on both for solids and also liquids. Initially only for solids, liquids are able to pass nicely. It is only mechanical obstruction, unlike achalasia. Later on, neither solid nor liquid, the moment obstruction is total. One simple way in a case of dysphagia, you can recognize that it is esophageal cancer. What is that? Patient will be cachexic. Severe weight loss will be there. That much severe weight loss won't be there if it is a dysphagia due to achalasia or dysphagia due to any other reason. Only when it is a malignancy associated dysphagia due to esophageal cancer, then only weight loss will be very significant. Easy fatigability, anemia, etc. will be there. Sometimes if it is very early part, patient may look absolutely normal. Once it became advanced, supraclavicular lymph node and patient will be severely cachetic. One patient of esophageal cancer, if you see, you can never forget. Severe emaciation. Food doctor, food. All life is meant for search of food throughout civilization. If that food cannot go inside due to esophageal cancer, a person is as good as bones and dust. So that is very important. So supraclavicular lymph nodes, mediastinal lymph nodes, it can spread because lack of serosa. Then it can also go to gastric nodes, it can lead to pericardial effusion, it can lead to pleural effusion, it can lead to dysphagia, dyspepsia. All these are the part of a clinical story of a patient of esophageal cancer. So how will you diagnose, doctor? Barium swallow will make you discover that there is a mass. Barium swallow is a very important investigation. Chest X-ray, you can discover any lymphadenopathy. If you do esophageal duodenoscopy, it will also help you to discover the mass and also take a biopsy. And CD scan of the thorax, why will you do? To know the mediastinal spread, extent of the disease and plan for the management. Now let us see through some classical clinical situations. Normal squamous lined mucosa. And this is an example of this part is partially malignant ulcer. This is all that inflamed Barrett's intestinal metaplastic epithelium endoscopically. So this is how the esophageal malignancy. Endoscopy will help also you to take a biopsy. This is another example of how, what is the role of the CT, which can help you to identify the mediastinal spread basically. So this is an esophageal cancer where the subcarinal group of lymph nodes are basically involved in case of esophageal cancer. Then now what is the most sensitive investigation, which is more sensitive than the CT scan? Endoscopic ultrasound. You will do endoscopy, same time you will do, it will have an ultrasound probe. So what you will discover? There is a typical mass lesion which is involving the wall of the esophagus. So CT may miss it, but endoscopic ultrasound can be able to pick it up. Then we will also do bronchoscopy to the patient. So that you want to know, esophagus, trachea are the two tubes. One takes air, other takes food. So food pipe cancer can involve air pipe in simple terms. So you also need to do a bronchoscopic evaluation to discover whether there is any bronchial involvement due to the esophageal cancer. Then PET scan, positron emission tomography, will enable you to know whether any regional lymph nodes are involved and distant metastases are there. PET scan is very, very useful. So how will you treat, doctor, esophageal cancer? Most of these patients are symptomatic at the time of the diagnosis. Only when he becomes cacatic, can't swallow also, then the patient will come to you. Most of the times they have an advanced disease. It's a bad news that you need to give to the patient. The liver, the lungs, pleura, lymph nodes, there's involvement diffusely because esophagus doesn't have a serosa is what needs to be remembered. That's the reason if you take esophageal carcinoma patients, only less than 40% are fit enough to undergo any curative surgery. Then even if you do surgery also, the response is poor. And most of the times we end up in doing surgery mainly to relieve the traffic jam caused by the mass. So metastases are there. So most of the time surgery is meant for palliation in case of esophageal cancer. More than 20% of these patients will have fistulae, abscesses, respiratory complications because trachea and esophagus are very close. You can give radiotherapy, can you? Yes, it will be able to shrink the tumor. So that just like lymphomas, not lymphomas, other cancers, their radiotherapy has a role of tumor bulk shrinkage. Even that has a role of shrinking the tumor and relieving the obstructive symptoms. Also you can give endoscopic gun. Laser is there, no? 007, James Bond will push the laser and burn the malignancy. If the esophagus is blocked, you can place a stent to maintain its patency. And you may end up in doing gastrostomy. If esophagus is all traffic jam, take a route directly to the stomach and push the food into the small intestine. Gastrostomy, jejunostomy tube is what you will basically place. These are the basics. Now let us look into a few clinical pearls for the exam. Unless 60% esophagus is blocked, dysphagia does not usually develop. If I ask you what is the 5-year survival rate, less than 5% is esophageal carcinoma. 90%, what is the histology, doctor? Squamous cell carcinoma, and it occurs in the upper or middle third. 8% are adenocarcinomas, but nowadays adenocarcinoma incidence is also basically increasing. It occurs in the lower 1/3, and about 15% of the adenocarcinomas are associated with Barrett's epithelium in the background. If you take squamous cell carcinoma, it is very radiosensitive, but adenocarcinomas are not radiosensitive. That's the reason no role for radiation to shrink the mass if it is adenocarcinoma. Favorite question of examiner. So, in case of squamous cell carcinoma, you can use either radio or surgery, but adeno, there is no role for radiation. Obviously, what is the favorite question whenever we operate? Colon or anywhere? How many centimeters margin? Mera margin kitna hai? So that is important. 10 centimeters proximal clearance is required from the place where the esophageal mass is located, basically to avoid a submucosal spread. See, you may see mass in this place visibly, but submucosally it will spread about until 10 centimeters. That's the reason mass plus 10 centimeter clearance. If you only remove mass and think I have done everything, already submucosally it has spread, no, that will once more grow back. 10 centimeter proximal margin is required. If it is adenocarcinoma, it is in the lower 1/3 of the esophagus, no? So how do you basically treat? total gastrectomy by a thoracoabdominal approach is very important in case of adenocarcinoma. Now, doctor, if you look at esophagectomy, which is the main surgical procedure for removing esophageal mass, there are two methods of doing it. One is called a two-stage esophagectomy called Ivor-Lewis surgery. Other is called three-stage esophagectomy called McEwan's esophagectomy. I really don't want to go too deep into it. No use. If you know a lot of things about it also, it's very low yielding for exam. If you know what is two-stage, what is three-stage, enough. Still you have that enthusiasm to read, read Bailey daily. So you always have a beautiful literature in Bailey and Lau surgery. Then transhiatal esophagectomy. Diaphragmatic hiatus, esophageal hiatus is there, no? So through that you will put the hand and plug out the esophagus, transhiatal. Then that esophagus, whenever you do palliative surgery, you need to maintain the patency of that. So, because that is the only way by which food can be pushed down into the small intestine, into the stomach and small intestine. So, how will you maintain the patency of that esophagus which is collapsed in esophageal cancer? You can do open surgical intubation, but that is now obsolete. Forget about it. Endoscopically, under the endoscopic guidance, you will basically place some stents and tubes. Common tube which is being placed endoscopically is called Atkinson's tube. Only that Atkinson's tube is what you need to remember for exam. Then you also have self-expanding stents. Nowadays, balloons, stents is what you call interventional cardiologist domain, no? So then why don't you give a self-expanding stent which will go as a small one and then blow out there and maintain the patency of esophagus. That's what you will do. Now laser, typically it gives a very good palliation by destroying the esophageal cancer tissue in about 60% of cases. But you need to repeatedly lasering every 4 to 6 weeks. And about 5% of cases while receiving the laser beam can develop perforation of the esophagus. Then one important point you need to know about esophagus anatomy, surgical anatomy is, if you look at the lymphatics of the esophagus, they run longitudinally through and through the length of the esophagus. That's the reason even if the visible tumor mass is small only, it already has spread submucosally almost 10 centimeters along the length of the esophagus. That is a special feature of esophageal cancer. Then what is obviously the TNM classification? T1 means to lamina propria without breaching submucosa. T2 is to muscularis propria. T3 is to adventitia. T4 into the surrounding mediastinal structures. Now doctor, in every cancer, what is our discussion? There is some main therapy, there is some adjuvant therapy. Adjuvant can be radio or adjuvant can be chemo. What is the protocol in case of esophageal cancer? No role for the adjuvant chemo or radiotherapy. No role is what you need to basically remember. Only thing is, after you have removed, you can give adjuvant radiotherapy to that margin, surgical margin, in order to decrease the local recurrence. But otherwise, as such, there is no role for radio and chemo. And for staging, if I say, what is the most valuable investigation? Not CT, not barium, not only endoscopy. But what is your answer? Endoscopic ultrasound. We have seen in the earlier image that's very valuable to stage better than CT, especially for whether it is submucosal, whether it is muscularis, which layer is involved in the wall. If you want to know, endoscopic ultrasound becomes a very important investigation. 2-3 comments about the surgical approaches. See, esophagus passes from where to where? From neck through thorax into the abdomen. It belongs to Kali Yuga, Treta Yuga and Dwapara Yuga. All the three segments it passes. It's a very old embryological structure. So, how do you basically approach the cervical part of esophagus if you find a upper 1/3 of esophagus malignancy? Neck has a right side and a left side. Left neck is where you nick to approach the cervical esophagus. Why, doctor? Because if you take the midline, esophagus is not on the right of midline but on the left of the midline. Sometimes this kind of simple facts can be the bottlenecks in the exam. Then if it is a thoracic esophagus, how will you basically approach? It is the right thoracotomy called as Ivor-Lewis through which you will be approaching. If it is the lower esophagus, how do you best approach? Ignore this 333. This 3 is basically a little typing mistake. Lower esophagus, how will you approach? Left thoracotomy plus ciliotomy. Because lower esophagus is also going into abdomen. So, the various surgical options which you need to remember, when it involves lower 1/3 of esophagogastric junction, then if it is involving lower middle 1/3, what will you do? Upper 1/3, what will you do? If it is in the post-cricoid area, what will you do? What will you do, doctor? If it is lower 1/3 or esophagogastric junction, if the tumor is there, then total gastrectomy plus or minus Roux-en-Y loop. Then if it is involving the lower middle 1/3, lower or middle 1/3, what will you do? Esophagogastrectomy. You remove that part of esophagus and connect the upper esophagus with the stomach. Anastomosis you will do. If it is involving the upper 1/3, what will you do? You will do esophagectomy, and from the colon, you will take a part of colon, which can act like a replacement for that removed part of the esophagus. Because you can't perform an anastomosis at the level of upper 1/3, no? Right? So, you will do colonic interposition after doing the esophagectomy. If it is the post-cricoid area, what will you do, doctor? Once more, you will be doing esophagectomy plus interposition graft brought from colon. That's what you will basically be doing. So, whenever you do resection, you have a 3-hole procedure. Forget about the first 3. I am talking about the second 3. Left neck you will nick. You will do right thoracotomy. You will also do ciliotomy. That will give a complete exposure to the entire esophagus. Here you made an opening, you have seen cervical part. Thoracic part will give you exposure to middle 1/3. And abdominal laparotomy will give you chance for lower 1/3. But it has got a great morbidity is what need to be remembered. Then the other is, without doing any thoracotomy, what you will do is transhiatal. Through abdomen, through the esophageal hiatus, you will approach, you remove it, you remove the required part of esophagus, and basically you will make a anastomosis, that is transhiatal. It has a lower morbidity and but the main problem is what? Here you are not directly seeing that part removed because you didn't do any thoracotomy in transhiatal procedure. That's the reason it has a greater chance of leaking. Higher leak rate is typically is the problem. Then lastly, one point of interest is photodynamic therapy. It has a great role where you will be injecting a non-toxic chemical into the blood, which will sensitize the malignant tissue, which will then respond to laser beam much more effectively, called photodynamic therapy. Also has a role in the management of esophageal cancer.